45 multiple choice matching. And maybe a little less than that, maybe about 42. And then you have a couple short answer, and a couple essay questions. Because I'm not here on Friday, and you won't have me to ask questions, because I really prefer to answer your questions while you're taking the test, will you just make a notation on the side of the question, so that I know that you didn't get it, or you didn't understand the question? So that when we go over it, I mean, I don't want you guys to miss points because you just simply didn't understand what I was asking. So just make a notation on the side, and then when we go back through it, we'll make sure that everybody understood the question when they get the answer. That's it. Okay, a lot of my questions, not so much on this test, but in future tests. We know that certain things that can happen to specimens will cause that specimen to be no good, right? We know that hemolysis can affect things. We know that lipemia can affect things, and icteric can affect things. So when we get to learning those things, I ask you a question. They're usually a two-part question. And the first one was, would you accept or reject the specimen? Okay, so again, if the specimen is grossly hemolyzed, would you accept or reject? Please do not tell me yes or no. That is not what I'm looking for. You can circle reject, or you can circle accept. Yes or no is not a good answer. And then usually those are 2-point questions, so the next one probably would be what, or what would you do, or sometimes. So again, pay attention, because sometimes, and a big clue bird will be for you, like my multiple choice are 2 points. Sometimes my matching are only a point, but if you see that it's a 4 or 6 point question, then you know there's probably more than one part. Does that make sense? Okay. And so just kind of look, because it'll say like, would you accept or reject, and then why might just be one little word, and then so you want to make sure that you answer the question. And I'm not here to answer your questions, that's why I feel bad. And Diane's already told me she didn't know anything about chemistry, so, but hopefully it'll be okay. So your quiz or your test on Monday will be over the 3 PowerPoints that we went over so far. And we can go through them real quick, and I'll tell you what I'd know if I were taking the test. So the first one would be the introduction. And I'm going to go slide by slide and tell you what I'm going to ask you. So on slide number 5, we talked about volumetric equipment, and we used volumetric pipettes yesterday, did we not? So can somebody tell me, how do you use a volumetric pipette correctly? And just kind of give me the quick steps. What's important? Holding it vertical, right? Looking at the meniscus at eye level, okay? Our volumetric blowout.
You don't know.
What do?
You tap it on the side.
Tap it on the side. Exactly right. Exactly right. So some of that was on 5 and some of that was on slide 6. Okay, we also used micro pipettes yesterday. Micro means small, so you know you were using small volumes, correct? This is slide number 7, I'm sorry. Micro pipette. So what's important to remember with a micro pipette that you did not do with your volumetric?
Blow it out.
Blow it out, and you also had to rinse. Very good. Yeah. On slide number 9, what type of glass were the cuvettes that we were using? The cheap ones. What's it?
I know it's over the
It starts with a V.
Borosilicate?
Yes, borosilicate glass. You got it. When you're cleaning the glassware, remember it's kind of like doing your dishes at home, but what is the one CAP requirement that we have to do for cleaning glassware? Check the pH. So if the pH is low, what does that mean?
It's not clean.
What's making it not clean? And if it's too high? Basic. So we're basically looking for what number?
7.
That's the range, but a 7, which is neutral, right? Okay. All right. So in the lab, we have reagent water. This is slide number 10, okay? What type of water this is what I made you go get yesterday. What type of water are we mainly gonna use? When I ask you to go get water for a procedure, what water am I talking about?
Type 2.
Type 2 water, distilled, exactly. Okay, when we were talking about acids and bases, what did I tell you you should not do? I'm sorry?
Add water to it.
We always add acid.
Yeah, I always add the acid to the water, and you're never supposed to taste, sniff, wash your hair in it, sweeten your coffee with it. Right, you treat chemicals how they're supposed to be treated. And how would you find that information out?
SDRs.
You got it, good question. You're going to, this is going to be a fill-in. You're going to define for me, this is slide number 15, I'm sorry. You're going to define for me precision and accuracy. You're going to have to actually write out the definition. And you can make it very simple. Precision is reproducibility and accuracy is closest to the result. You can honestly say most people just kind of flip-flop them, so just pay attention to where you write your answer. Okay. What's the difference between an assayed and an unassayed external control? Right. So the assayed one is going to come with an answer sheet. And the unassayed, you're going to determine that level by running it numerous times in your laboratory. Very good. Very good. Okay, quality control charts. What's the name of it? This is the question that was on your pretest. So what is it? What's the name of the chart that you write your quality control results on?
Levy-Jennings.
Levy-Jennings, yes. And then you have to know shift and trend. Don't believe those are fill-in. I just believe that it's a multiple choice question. Shift and trend.
Shift is where it's on one side, trend is where it goes up or down.
Trend is like it'll either go down in one direction or up in one direction. A shift means it just shifts to the opposite side. We go straight across.
There has to be 6 points before it's considered a shift.
Yes. Although my boss gets mad at 3. Technically, it's 6. Not, that was instrumental. Or that, I'm sorry, that was the introduction. Instrumentation. You're going to be able to pick Beer's law out of a lineup, right? And what does Beer's law basically say? It is the mathematical expression, a relationship between the absorbers and transmittance, correct? And I'm going to give you several formulas, and you're going to be able to pick them up, pick it out of the lineup. Easy, right? Okay, on slide number 5, why did we do a band pass? What did the band pass tell us about our scope, our spec?
Quality of it.
The quality of the spec. You got it. You got it. In the spec that we have in our laboratory, what is the light source? Tungsten lamp. Yes. What is this is slide number 8. What is the most common type of monochromator used in a spec? What do we have?
Diffracting.
Diffracting, yes. And I didn't tell you this yesterday, but it's actually 15,000 to 30,000 etchings in that glass per inch. You don't need to know that. That's just a little fun fact. If you're at a cocktail party, you can share with someone. when we did, this is slide number 10. When we did the band pass procedure, what were you putting into the spec for wavelength accuracy? So it uses a
Holmium oxide.
Oleum oxide glass filter, yes. And what were we determining? What were you changing?
Wavelength.
Wavelength, so it was for wavelength accuracy, right? So we were using that filter for wavelength. Okay. This dealt more with your hemoglobin and hematology, even though we did talk about it. What did you blank with in your hematology procedure? Drabkin's region. And so what was the reason for doing that?
So
what
it,
does a blank do?
it tells the machine this is what it's normally, or without anything, any blood or anything in it.
Exactly. You want to fake the machine out thinking it's seeing 100% of the light
Yeah.
when technically there is something in there that would block it out. Does that make sense? So do you have the answer sheet to your instrumentation? I'll tell you which ones I feel if I was I can find my cheat sheet. Okay, so what I would know, now again, I'm telling you enough to get you a B. If you want an A, you gotta know them all, right? You know the spectrophotometer. You know you need to know that one inside out, upside down. You know all the parts and the principle and what we did for wavelength calibration and all that good stuff. So you know the spec. Atomic absorption, you want to know the principle behind it. Fluorometry. Nephelometry. Nephelometry, if you can remember scattering. You can just remember scattering. That's going to be your big clue on that one. Ion selective electrode. Serum protein electrophoresis. And migration. You can remember the word migration with SPE. That's going to be your big clue word there. And then as far as chromatography, liquid, gas, again, the principle behind those two. Osmometry, you will get in another lecture, and it's probably have another test. I don't think it's on this one. Those for sure. So they're going to be matching. I'm going to either give you the principle, and you're going to have to tell me what the methodology is, or I will give you the methodology, and you're going to have to find the principle. Make sense? All right, and the last one is carbohydrates. In a nutshell, what is a carbohydrate?
Sugar.
Sugar. And why do we need sugar? Yep. Get your brain working, right? Okay. So a disaccharide we said was what? 2, right. So if I took a maltose and took it apart, what would I have?
2 glucose.
2 glucoses, right? Because the glucose is a simple sugar, correct? Okay. You're going to need to know the definition of, so I'm on slide number 10. You're going to know the definition of glycolysis, glycogenolysis, glycogenolysis, and glyconeogenesis. And you're gonna run into those a lot. So I don't know if you guys are index card people or not, but that is, you're gonna run into those terms a lot in this class. So. Okay, so let's talk about the hormonal regulation of glucose. What is the one and only hormone that will decrease your blood sugar? Insulin. Insulin comes from where?
Beta cells.
Okay, where in the pancreas?
Beta.
Beta cells in the pancreas, yes. Your pancreas, beta cells, your pancreas actually secrete what? I'm on slide number 13. What does it actually secrete? Proinsulin, right? And then your body does what to it?
Breaks it.
Breaks it apart, okay? What is the inactive fraction of that?
C-peptide.
The C-peptide. So what is the value in ordering and running a C-peptide?
Lets you know if it was natural insulin or if you have injected yourself.
Right, so exogenous, you injected yourself, versus endogenous, your body made it, right? Yes. Very good. Okay. So what hormones will increase your protein? Or glucose, I'm sorry. Pretty much all the ones except insulin, right? Yes. Yes. So the primary hormone is glucagon. That will increase your blood sugar. Where does it come from?
Alpha.
Right. So insulin comes from the beta, glucagon comes from the alpha, right? So this is a matching. You're gonna have to match those terms to their definition. What is insulin? What is C-peptide? What is glucagon? Where does it come from? That's gonna be a matching. Okay. And those, like I said, most of my matching are only broken. On slide number 15, we talked about glycosuria or glucosuria. Why would you have glucose in your urine?
Too much is spilling over.
Exactly. I don't know if Jean's talked about it in your analysis yet or not. Have you gotten that far? Probably not. Yeah. So yes, once you're too sweet, your body says, I don't want it back, and it's going to let it go. Right? So what value does having a glucose in your urine tell the physician? Is it normal? No. So what is that telling him?
You're not breaking it down.
So you're probably
Not breaking it.
not necessarily too much sugar, so it's that what disease state is associated with high blood sugar? Diabetes. You got it. Which takes us to our class of diabetes. And there are some questions, and we'll go over here too, but that worksheet that you did, all right? So I'm going to give you a set of characteristics, and you're going to tell me, is it type 1, type 2, or MODY? And you do realize that some of them have multiple answers, right? So you could have 1, 2, or all 3 as an answer. Okay. Type 1 diabetes is your cell-mediated autoimmune, right? That's pretty much on that worksheet. And then your characteristics. Well, I would mostly study, like I said, that worksheet. That's pretty good. It's really helpful. Type 2 is the most common form, genetics are largely involved in your problems, complications, pretty much what, like I said, what's on your worksheet. So I'm going to give you a characteristic and you're going to tell me which one it is. Gestational diabetes, same thing. Gestational diabetes happens when you are pregnant, yes. MODY is a gene mutation, correct? So it's, again, hereditary. Slide 22. Okay. You with me? On slide 23, there is a question on your test about the homozygous and heterozygous of MODY. Which one's more severe?
Homo.
Homozygous, yes, because you have 2 abnormal genes. Slide number 24. Okay, it's hemoglobin A1C. Who wants to tell me what a hemoglobin A1C is?
It's the level of glucose that the body has reduced over like 3 or 6 months. Basically, it tells the doctor if they're been actually keeping their insulin and glucose levels where they should be, or if just that day in the doctor's office they were.
And how does he know that? How does it do it? What's the mechanism behind it?
It holds on to the sugar, doesn't let go.
What holds onto it?
The hemoglobin
Yes,
A1C.
the A1C fraction of the hemoglobin. While that, so how long does that red blood cell cycle in your body?
120.
120 days, right? So while that red cell's going through your body for 120 days, glucose is glopping on and it does not come back off. So if you've got high blood sugar, it's just gonna keep glopping on and glopping on and glopping on, so your A1C is gonna be high, right? Okay. So if you had, let's say your red blood cells lived for 360 days, how would that affect your hemoglobin A1C? Higher, right? Because that red cell's circling through much longer, okay? What if you have a hemolytic anemia and your red blood cells are rupturing at 10 days? How's that gonna affect your A1C? It would be lower, right? Because we're going on a normal of 120 days. Make sense? So if it's not cycling, then it's not picking up that glucose. The longer it's in there, the more glucose it's gonna get, the less time, the less glucose it's gonna get, right?
People actually have blood cells that live in it.
No, I was just making
Oh,
that
I
up.
was like, what?
No, I'm just trying to get the point across that the longer it's in there, the higher your A1C is gonna be.
Okay.
Yeah, I mean, you guys know how all that works, right? Your spleen is your quality control officer and it pulls them out, all that good stuff. No, I was just making that up. Okay, so, somebody tell me, well, you kinda just did. What is the value of a fasting glucose that you did today? What did that really tell you?
If you have diabetes,
Not necessarily, but what did it tell you? That you did pretty good last night. You didn't eat any sweets after 10 o'clock, right? But it didn't tell you anything else. You know?
break down the sugar.
And so you were normal in the morning, right? But what does your A1C tell you? You kind of alluded to it a few
That
minutes
if
ago.
you're normal throughout the, like, I think, is it 3 months? Or is it
120 days, yeah.
So 3 months if
Right.
you've been normal or
Right.
you've been
So tell
cheating.
you about compliance, right? Are you really watching your blood sugar or are you just being good that day? That's gonna be an essay question, okay? But again, correlation between what's a fasting blood sugar telling you and what's a hemoglobin A1C telling you. Okay, fasting blood sugar, yeah, okay, you were good today. And you do need to know your fasting blood sugar normal. And you do need to know your A1C normal, because that will help you answer that question. And I have your hemoglobin A1C is greater than or equal to 6.5. Is that really right? Because it's not, it should be less than. Is it
Well,
less
on
than?
Is it less than or equal?
On the lab testing, you had normal ranges 4 to 6%.
Okay. Oh, okay, I'm sorry, diagnosis for diabetes, that's what it said. That's not right, okay. So on slide number 24, diagnosis of a glucose or diabetes mellitus, you have to realize you do not have to have an oral glucose tolerance test to be diagnosed with diabetes. Symptoms, you walk in and you tell the doctor, I'm thirsty all the time, I'm going to the bathroom all the time, and he does a blood sugar and it's greater than 200, he can diagnose you with diabetes. So symptoms, you do not have to have that oral, that glucose oral test will confirm it, possibly tell you how severe, but that's not all he needs to diagnose it, so. On slide number 26, what is hypoglycemia? Hypo means low, that's your low blood sugar. So if normal is 65 to 110, what kind of a value would we be expecting with a hypoglycemic person? Less than 65, about 55 would be good. Yep, you got it. Okay, so laboratory tests on page 20, on slide 28. What is your reference method? So glucose measurement, fasting blood sugar should be 65 to 110 milligrams. Then right under that I have glucose will decrease 3 to 5% every hour if the serum or plasma remains in contact with the cells. Because because your cells are still living in that tube. Those cells are utilizing your glucose, yes? Okay. So if I drew a blood sugar tube on you this morning, and I put it in a red top tube, which has no serum separator gel, and I just left it over there, and then at the end of the day, I'm like, oh shoot, I need to spin that down and run their blood sugar. What is gonna happen to you? What value of blood sugar gonna be? Right. So let's say we did the glucometer this morning and you were a sweet 130, whatever you were, I don't remember, okay? And then I were to run that glucose and I'd be getting a 98. I'd be, well, okay, she's normal. Why? Why was there such a difference between the finger stick you did this morning and the red top tube I ran this afternoon? You just told me.
Because it decreases.
Because
It sits
the
on
cells
this
are alive
side.
and they're
Yeah.
still eating that glucose in that tube. Exactly right. Make sense?
Mhm.
So we have that's a big problem in the hospital because they will do a the finger stick on the patient in the bed, and then the result won't be what they like, and they'll draw a specimen and send it down to us. Well, sometimes they're not quick about getting it down to us. And then they're like, well, wait a minute, I got 240, how come you're only getting 175? Well, it sat up there on the floor for, 6 hours and you didn't send it down. Yes, they do. You are exactly right. They do that a lot. Exactly right. Then you have to go explain to them what they did. So in class, on Friday, what you're going to have, Diana's going to give you your test first thing at 8 o'clock, and then she's going to have you go over and do phlebotomy. Because what I want from you are 2 SST tubes, so that you can run your own specimens when we start running these tests in the lab. And they are going to be SST, so I do want to make sure you spin them down. As soon as they're clotted, spin them down. So that then we can use the serum for the rest of the time. Make sense? So hexokinase we said was your reference method for glucose. We already talked about hemoglobin A1C. Anybody have any questions on A1C? Understand what that means? What is a I'm on slide 30. What would a microalbumin tell you?
Kidney damage.
That is one of the earliest signs. It's actually now protocol. I think when you go in for your 45th birthday screening and they say, okay, here's your screening for colon cancer, pee in a cup. I think they do that because it's one of the first early detectors that they can do. So I think they've added it to that kind of. And then we've already talked about insulin and C-peptide. Any questions on that one? Understand what the C-peptide is telling you, why else you want to order it. Any other questions? So we can technically be done by tomorrow.
Hey.